Welcome back to the Radian Podcast, your go-to source for digital product-focused discussions on design, technology, and digital health advancements. I'm Maxwell Murray, your host, and I hope today's episode inspires your next big idea. In this episode, you'll hear about...
So every patient at home is getting between 10 and 20 services each. So at 200 patients, you're now managing 2,000 to 4,000 discrete tasks every day. So having visibility into what's really going on in the field, what's on track, what's off track, and in many cases, without a software solution or technology solution, you don't know something's off track until it didn't happen. Digital governance is a framework for how decisions get made and funded. You should be able to justify your idea, what kind of impact you think it can have, and get them vetted and prioritized accordingly.
Welcome to the podcast, John. It's a real pleasure to have you on the show today.
Max, it's my pleasure to be here with you and your audience. Thanks for the opportunity.
Cool. And for our listeners, to give you a sense of the deep expertise John brings to our discussion, he has over 20 years of experience in healthcare digital leadership. For a significant part of his career, John served as the CIO for post-acute and home-based care for Mass General Brigham. In that capacity, he truly led significant digital transformation efforts, including the implementation of Meditech and later Epic EMRs across these vital divisions. Most recently, and this is an area I'm particularly excited to explore, John led the launch and impressive scaling of MGB's innovative home hospital program. It's quite remarkable how MGB scaled this program to 70 beds in under 2 years, a venture that undoubtedly required a complex set of digital solutions delivered very rapidly. And John's experience isn't confined to one setting. He's also held impactful roles in product and software development at well-known organizations like Beth Israel Deaconess and CVS Pharmacies, and also brings 6 years of perspective as an IT management consultant. So, John, with that incredibly well-rounded and impactful career, we're thrilled to get your insights today.
Happy to get into it, Max. Let's
Excellent.
go.
To start, let's talk about one of the most significant shifts in healthcare delivery. Mass General Brigham managed to create what amounts to $50 million in new hospital capacity, not by laying new bricks and mortar, but through digital solutions. Could you walk us through how you managed to scale the hospital at home model so effectively and the key lessons you learned in the process?
Sure. Thanks, Max. So first, as you mentioned, MGB scaled its program to 70 beds in under 2 years. This is unprecedented. At 70 beds, MGB has the second largest program in the country. However, it's the highest acuity program in the country. MGB is taking care of very sick patients at home. At our launch, we started by engaging a team of consultants to help us devise our operating and financial model, including how those models would evolve as we scale. We developed these models by identifying a number of work groups that we paired up consultants with members of our operations team and came up with solutions for how we would scale the model over time. We also had a digital consultant that attended all these work groups and cataloged all the digital needs that they heard in these discussions in the room. And that was the beginning of creating our digital work plan. We developed all this data that we collected to develop a digital strategy, and we scoped the work. We had to collaborate with many teams across MGB to do that. And ultimately, this formed our digital strategy and also our funding request. So we built a business case and we went to executive leadership at MGB and got funded to do the digital work in the millions of dollars. I can't say exactly how much. The day after we got funded, we began the process of hiring a couple of contractors to jumpstart the work. Simultaneously, we started hiring the team. And at scale, we had 30 FTEs doing work across multiple domains. So everything from doing modifications to our EMR, integration work, data and analytics, desktop and devices, telecommunications, project management, et cetera.
Wow.
The goal set by the system was very aggressive. The original goal was 200 beds in 2 years. That's what we call a BHAG goal, right? But regardless of the goal, that was the goal. So we needed to march towards it. And what that really meant is we were working on dozens of projects simultaneously with continuous coordination with operations on how to activate and roll out these different solutions. In the beginning, it was very chaotic, and we brought our project managers and we set up a PMO to really, again, organize our work. And then over time, we also were able to partner up with operations to get more organized on their side. And ultimately, we came up with a joint project management process that we called bundles. So we were literally creating bundles of content, and those bundles included new diagnostic categories of patients, the services we needed to take care of them, the education we had to provide the clinical staff to take care of them, and ultimately all the digital supports that were needed to roll out these bundles. And then we put those bundles on a timeline, and again, continuously developing and rolling out stuff across time. To do all this, we had to be incredibly agile. At the same time, we worked within a system, our organization, that was not agile. Most of the digital teams used a traditional sort of waterfall approach. And the system writ large just did not move that quickly. So we were being agile. We were using some of the agile ceremonies and trying to influence our peers on other teams to be more agile with us. We actually developed a project management methodology we called Agile Waterfall, because we were agile and we were working with teams doing waterfall and trying to make it all work together. In the end, it really took an all hands approach to building this new program, with digital working in partnership with operations and our digital colleagues to continuously scale this operation.
Wow. So it sounds like there was first you had to be convincing and package, state the issue, state the opportunity rather, in order to scale a hospital at home initiative and get the right people in the room, talking to one another, structuring teams, and then restructuring the way you work. And I really love the understanding of handling agile within a waterfall context. It's surprising that in 2025, there's still such a natural draw towards a waterfall approach. This item, then this item, then this item. What about concurrencies? What about delivering value to patients and clinicians in a more iterative sense? So it's interesting that you found a way to deal with the reality of how people work, yet still push things in the right direction.
I mean, in many ways, we were like a startup company that was operating inside of this huge bureaucratic organization, right? So in addition to trying to be agile, you're trying to move the environment around you, which just doesn't move all that easily, which, created some real challenges, but we powered through it.
Yeah. And one of those contributing factors, I imagine, is partnership. Talk to us about your partnership with Best Buy Health. It's a fascinating example of bridging two very different worlds. So we're interested in diving into that a little bit. And if you could share the story behind the collaboration and what you've learned about what it truly takes to build trust and success when pairing a large health system with an industry partner. And I think this is, tune in, listeners. This is an important part. We are hearing from a very experienced CIO and leader in the space. This is who you're trying to to sell to when you're creating these amazing products and innovations.
So I have to admit, when I first stepped into this role, I didn't know Best Buy had a healthcare division. And on its face, anytime I mention Best Buy Health, people are like, really, Best Buy, the big box store? So it doesn't make sense at first until you understand more what the strategy is. Best Buy established a healthcare division back in 2018 with a goal of being the consumer health tech supplier of choice. So they're already, known for being, a seller and supporter of tech. They've got their Geek Squad division, so they can come into the home and set up your tech and service your tech. And they also have a fantastic geographic footprint. So, it's well known within healthcare that something like 90% of the U.S. population lives within 10 miles of a CVS pharmacy. A similar percentage of the population lives within, I think it's 25 miles of a Best Buy store. So they have the geographic footprint as well as a strategic sort of asset. So initially they acquired a couple of consumer tech solutions. So one is what's called Lively. It's their fall detection. There's another, which is a phone-based solution. both sort of targeted the geriatric population. But then in 2021, really stepping up their entree into the space, they acquired a UK company called Current Health. Current Health is a remote patient monitoring platform. And in UK, home hospital is the norm. It's just part of the national health system. It's widespread, and Current Health was the solution used by the UK national health system. So again, in 2021, Best Buy acquired Current Health and became an RPM provider focused on the home hospital space in the US. The partnership really began because MGB and Best Buy had a shared vision. And that vision is that, care at home can span the entire continuum, starting from, wellness and everything from being fit to maybe monitoring, low-grade things like, things like fall detection and, having a smartphone and other things, but can extend all the way into sickness. So with things like RPM and being able to take care of very sick patients home, but ultimately following that patient all the way back to their healthy state. So MGB and Best Buy Health had that shared vision, and that was really the beginning of the relationship. One of the things MGB realized early on, because of that audacious goal of 200 patients, was that managing logistics at scale would be near impossible without a software solution. Right. So every patient at home is getting between 10 and 20 services each. And many of those are being provided by third parties. Right. So meals are, we're not sending meals into the home. Those are being provided by a third party. We have home health aides coming from a home health agency. We have supplies being delivered by, another organization doing mobile radiology and other things. We're sending our own staff into the home. But that's what makes up the 10 to 20 services. So at 200 patients, you're now managing 2,000 to 4,000 discrete tasks every day. And again, we're not providing many of those services. So having visibility into what's really going on in the field, what's on track, what's off track, and in many cases, without a software solution or technology solution, you don't know something's off track until it didn't happen, right? And so really the cornerstone of the partnership with Best Buy Health was to develop this logistics solution to manage all those logistics in the field, to provide visibility. I refer to as air traffic control for home hospital, to provide that visibility, to have alerts to let you know when things are off track, but also ultimately to be able to put, a schedule of events for the day for both the patient and also for the clinician who's overseeing their care. So if you're the patient that's on the receiving end of those 10 to 20 services, like you want to know what time is my nurse going to show up in the morning, paramedic in the afternoon, what time is the home health aide coming, where is my lunch? So absent a technology solution, all these things are just randomly sort of happening throughout the day. So that was the ultimate goal, was also to give patients visibility into their experience. We had a mind meld over creating this solution. And then, we both had to do a bunch of due diligence on it, right? So they had to do diligence on, what was it going to cost? What was the market, demand or need? And, at the end of the day, are they going to make their money back on the investment? And we had to do our own due diligence on them as a provider to be able to deliver on the solution. And so we had our, a digital oversight team together on the MGB side, from folks across digital, to really do diligence on the proposed solution and make sure that it was going to be technologically sound and meet our needs. We also, in parallel, spent time on putting all the contractual terms together. So, the basis of these partnerships is you in putting the contract together, you have to hammer out a lot of terms and a lot of concepts and a lot of details. And you also have to build into the contract accountability around things like timelines and so forth. And then also think about putting things like penalties if they don't meet certain objectives. And you hope you don't have to fall back on those things. A really good partnership is one where you don't need to fall back on the contract. That, by putting the contract together, you work out all the details and you're both on the same page. And then you hope you can put the contract aside and just focus on doing the work. but the contract's there if things aren't happening according to plan, or worst case, if you have to exit the contract. Again, you want to have all those terms worked out in advance so that, it's not, a battle at the end trying to get out of the contract. So again, we went through that whole process, and ultimately, we put ink to paper and we began the process of developing. That required putting a team together on both sides. Even though they were doing the software development, there were deliverables that we had to manage on our side, even just our participation. So that was part of the engagement. They were doing all the software development and creating this product, but we were providing the knowledge, the expertise, the sandbox, the test bed.
Yeah.
There were commitments on our side in terms of how much of people's times we would give at various stages of the project. And so we hired a small team on our side to manage all of that, to manage adoption. We call it org readiness, the org readiness to accept and adopt the new technology as it becomes available. And then we hired a third person to focus on integration, because this product needed to integrate with our Epic EMR and other applications. So we hired a team of 3 on our side to manage the relationship, and they had a whole team on their side managing the relationship. And overall, the partnership worked well. The teams worked well together on both sides. It took longer than we all anticipated, but ultimately the product will be delivered soon.
Yeah. So from hearing you, it was about vision alignment, having the right set of tools as an innovative group, trying to be a partner to a healthcare system, the magnitude that you were at, and on both sides, building out the team and structuring it in a way to align with the goals that were needed. And the most human-centered, insightful point for me in there was this notion of visibility. We're currently in the middle of a continuous glucose monitoring study where, there's already insights surrounding like the timing of notification of like glucose level and like what's going on with my body as a patient or as a clinician. What should I be reactive to? The timing, the communication of these digital solutions, and then also the training and communication skills of those that are using them and engaging with in patients is so important. So it's interesting that you surfaced that as something that everyone's looking for, especially with remote patient monitoring. We're not physically there. We're leveraging telemetry and all this technology to get a read. If the technology tells me after we're in the hot seat or in a bad place, that's not great.
Max, you touched on the shared vision, and it also occurred to me, there also has to be shared value, right? There's got to be something to gain for both sides. I've been talking to a lot of founders recently, and I'm hearing sort of consistently how frustrating they find it dealing with health systems. There's, the sales cycles are long, and it's really even just hard to break in a lot of cases. I think the takeaways from the story is, there's a timing element, right? Like there was, we needed a solution at a very specific point in time. Also, there wasn't a solution in the marketplace, so we needed to create one, which is why we went out and seeking the right partner. There had to be, again, shared value on both sides, and it has to be somewhat equitable, right? So both sides have to feel like they're getting a good return on what they're putting in. And then ultimately, there has to be execution, right? There has to be execution on both sides sort of keeping up their side of the bargain, if you will. And all those things sort of have to come together and work well. I also think sometimes, Best Buy is a more mature organization just because of their size. I think sometimes there's a mismatch between, the culturally, small startups and, large, complicated health systems. So I think that's another point, is having that sort of cultural match as well.
Yeah, no, sometimes culture gets underplayed, but you raise very good points. There needs to be an ROI on both sides, of course. It needs to be a sustainable venture, and you need to be on the same page, not only technically, or even like you were saying before, contractually. You need to be on the same page in terms of how you operate and move people in the right direction together. So beyond the hospital, the patient journey often involves like a complex web of skilled nursing facility, rehab hospitals, and home care. How do you approach digital transformation in such a complicated, federated ecosystem, ensuring both parties, the clinicians and patients, have consistent and high quality experiences?
Peter Drucker, who's a management guru, once said that the hospital is the most complicated organization man has ever created. And I think he's right, having spent a number of years. People sometimes ask, why people go into healthcare. And of course, there's the altruistic, helping people part, but there has to be a part of you that's wired to thrive in the complexity of healthcare. I refer to it as a Rubik's Cube that's never done. You just keep twisting, hoping that you get to the answer, but you never fully get there. Anyway, so my experience at MGB was in what's called the post-acute division. And a lot of people don't really understand the post-acute side of healthcare. Most of us understand acute, which is either going to a doctor's office, urgent care, emergency room, or being admitted to a hospital and having surgery. So that's the acute care system. Post-acute includes things like rehabilitation, and that's both hospitals and outpatient care, skilled nursing facilities. There's another variant called long-term acute care. These are hospitals that they're basically like big ICUs. They're hospitals that have very sick patients, long stays, et cetera. And then there's also home care and hospice, and now we have home hospital. So that was the portfolio of things I managed during my tenure at Mass General Brigham. So, early days, when I first joined, many of those entities were still on paper. And so we went through that first wave of transformation of actually getting things digitized. Most of them already had systems to do back office, billing, rev cycle, claims, et cetera, but not the front end clinical work. So that was sort of wave one. And our hospitals used Meditech. We used other solutions in skilled nursing and home care. But the point is, each of our entities had a different solution. Even the Meditech hospitals each had their own instance of Meditech that didn't talk to each other. So we were able to get them, digitized, so that they were digitized within each entity, but they still couldn't really exchange data across entities. So, good progress, but not an ideal state. So the second wave of transformation came with our Epic implementation. And so Epic really created an opportunity for us to have a single electronic medical record, not just across all of post-acute, but across all of Mass General Brigham. So now we had a single electronic medical record across acute and post-acute. And what that really means is no matter where the patient went, whether they went to see their PCP in the office, whether they went to urgent care, whether they showed up in an emergency room or at one of the many levels of a post-acute care, the electronic medical record was the same and it was complete. In our previous state, you could go to the Mass General Hospital and be discharged to one of the Spalding hospitals. And even though both had their own EMR, the patient still showed up with a printout of hundreds of pages of paper. And that's how the information got transitioned from one setting to another. So now with Epic, we didn't have to do that anymore. Every clinician everywhere in the system had the same view and the same data to work with. What that also meant, now we're doing fewer duplicate tests because, we couldn't see the radiology results at Mass General, so we'll repeat them here. So, there was a lot of that going on across the system. So we didn't have to, a lot less repeating of tests, a lot less of sending patients back out to the emergency room because we know something's going wrong with the patient, but we don't have the whole picture. And also being able to share resources more across sites. Prior to Epic, we couldn't even staff a nurse from this hospital at that hospital because even though they were both on Meditech, the implementations were slightly different. And, the nurses would have to be trained, cross-trained, to work in multiple locations. And so pre-Epic, that wasn't a thing. If you were a nurse at one hospital, you sort of stayed there. And now we have more opportunity to share resources across sites. I do want to get a plug in. Mass General Brigham was the first system in the world to run Epic across both acute and post-acute, because prior to our implementation, Epic hadn't tailored their EMR to work in post-acute settings. And at MGB, we thought that was important. So when we signed a contract with Epic, we got them to agree to develop solutions for post-acute care, and we co-developed. So it's another example of a partnership, not as structured as the Best Buy partnership, but there was a fundamental, agreement and a shared vision. And again, we partnered with them to co-develop the things that were missing for rehab, long-term acute care, and skilled nursing. Again, ultimately, we were the first system to go live with Epic across acute and post-acute.
The plug is welcomed, because it's something that's incredibly important to me when I think about this, and I'm sure to others. Like, interoperability and the life cycle and journey that it's on is sometimes not always encouraging, to put it politely. I personally have a bookmarked tab in my browser of various portals from my various healthcare providers here in New England, and I got to bounce around and figure out who has what. And I think of myself as a digitally native user. I understand technology fairly well. Then I start to think of aunts, uncles, maybe some older users, or maybe some people that are just not great with technology and what their experience is, to try to unify things. So we're trying to reduce the complexity in healthcare. And I understand that there's a lot of good reason sometimes for things to maybe be siloed off or separated, but it's incredible. I didn't know that before this conversation, that your early work with Epic and the systems you've worked on helped drive things in the right direction.
Yeah, and Max, it's 2025, and we take the rate of change of technology is astonishing, right? And we take for granted today how much is digitized. It was only in 2010, during the Obama administration under the ARA, the American Recovery Act, that $20 billion of federal money got earmarked for electronic medical record adoption. So prior to 2010, only 20% of hospitals had an EMR. Hospitals and doctors' offices, less than 20%. Wow. And now it's in the high 90s in terms of percentage. So some of these stories probably might sound very old fashioned, but that's an astonishing amount of progress in 15 years.
Agreed. We're talking about these solutions, and I know that everyone's been watching the market and concerned about where government spending and perspective on healthcare will go. And I think we're hearing lowered costs for healthcare and less dependence on government-backed funding to get patients treated and cared for. It's the sensation and read I'm getting in the marketplace. And I've been talking to innovators just in the past 24 hours, even just sending notes like, the solution you're building is super critical now more than ever. Don't be discouraged by this sense, but be encouraged by it, because innovation often brings one important factor to it: reduction of costs while increasing value. What's your perspective on how things are shaping up in that regard?
Yeah, no, I absolutely agree with you, Max. I mean, the next generation of digital healthcare is really going to be focused around AI and all of the opportunity and promise that brings, and also being able to move care into alternative, lower cost settings, right? And having the majority of the health system on an electronic medical record is really table stakes to even, try to begin to accomplish that next wave of work. So AI and all that it can do is not meaningful if you're not already on an EMR, right? Also, if you're not on an EMR, you can't easily move care to home or other settings. So we're now in an era where, an EMR is, table stakes. It's like the minimum, right? It's the foundation. And now it's enabling all these other things. And also enabling beyond AI, the EMR is at the core. And now we're going to start to see sort of a constellation of other solutions developed around the EMR that will continue to, digitize, automate, and transform healthcare. But to your point about cost, yes, we now have virtually everything automated and digitized. We have data, and we can now use that data to start to drive down costs, right? So we're well positioned from all the work that we've done over the last 15 years. And yeah, the next era of digital health is going to be exciting.
Yeah, and I agree. And I there's one more angle to discuss, because yes, cost comes down. What do you think that means for the value of the patient? What I'm getting at is like this notion of, like it's going to be good for healthcare systems, certainly if cost reduction is achieved. But then what I see is simultaneously figuring out how me and my loved ones can heal at home or avoid that extra hospital visit. Does that count as, you think, an experience booster, improve quality of life?
Yeah, it's no question that we are in unprecedented times in healthcare in terms of hospitals and health systems really being under enormous strain. There are capacity issues virtually everywhere. Capacity meaning more patients than we have staff to care for, or beds, et cetera. And so, it's a really challenging environment today for patients, despite all the work we've done and all the focus on patient experience. Just the larger kind of forces and market forces in healthcare are really preventing us from making good progress on that patient experience. Again, I think the things that are coming with AI, with shifting care to other settings, it gives us an opportunity to really truly refactor how we deliver care. Because the challenge is, people are always going to have to go to the emergency room, right? But something like 70% of care that's delivered in the emergency room can be delivered in other settings, right? So that capacity crisis is somewhat self-created on our part. We just have to find a way, to identify that 70%. We probably already know what it is. If we know that it's 70%, we know, somebody has studied this and can articulate what those things are that can be cared for in other settings. But then we have to create a system to be able to provide that care in other settings. And, it's happening slowly. We've got urgent care centers. We've got, there is even emergency care at home. So there's companies like Dispatch Health that, they'll dispatch a paramedic to the home instead of having the patient come to the ED. So, it's happening slowly. And I think, to answer your initial question, I think, I think a lot of these technology solutions are going to drive care to settings where we have an opportunity to provide patients a better experience than they're having today in both emergency rooms and inpatient settings and in doctors' offices across our healthcare system.
Excellent. Your role seems to go beyond a traditional CIO's. There's this idea that the lines are blurring between product, operations, and IT. Could you talk about your philosophy on this and how you use digital strategy as a direct operational lever to drive change and efficiency?
What's happened over time is that the role of the CIO has evolved from someone being a technology leader to somebody who is a business leader who happens to be responsible for technology. What that means is that today, CIOs, digital leaders, have to partner and work with operational leaders. And again, that word partnership, they really have to work together to optimize their business. So digital leaders need to lean in and understand operations well enough to see where the opportunities are. And our operational leaders need to lean into technology enough to own the solutions in their departments or their span of control. An ideal state would be operational leaders understand technology enough that they come to digital leaders and say, hey, I have this need. Either it's a new feature I know is either available in Epic or coming in Epic, or, I need a solution. And, let's go out to the market together and find a solution. To me, that's sort of the ideal, is that an operational leader is so digitally mature that they can be really effective sponsors of digital. But that's also part of the CIO role, right? Is like helping develop operational leaders to be digitally aware sponsors. Is also part of the CIO role. It's doing the education and sort of cultivating that relationship. I mean, MGB, I would say today is a very digitally mature organization on both sides. Again, they've got, I think most of the digital leaders are operationally mature, and I think a lot of the operational leaders are digitally mature. That you don't see that consistently in organizations today.
I think that's a profound insight. You have to be speaking the same language. You have to be able to identify capabilities. Some technological solutions do not work with the operational model of the facility or the healthcare system that you're in, or vice versa. You're trying to pull off a service or a experience for patients, for clinicians, that either due to technical limitations or regulatory limitations or just flat out policy can, for good reasons, may never be possible. And if you don't have mature operators and mature technologists, you can't have the conversations to discuss when we should rethink a policy, when we should rethink a procedure, and when we should, explore that really amazing presentation we saw at a conference that we want to bring home to the hospital.
Yeah, absolutely. And part of that, I will also say, part of that relationship is, CIOs, we talk about the shiny object syndrome, right? So, because since you mentioned, coming back from a conference, so that's also part of the role is, somebody comes back from a conference and they heard whatever, that, AI is going to solve everything or whatever. And vendors sometimes can exaggerate, the capabilities of technology and products. So that's also part of the role is sort of managing that shiny object syndrome and really helping, again, educate people on kind of, what's real, what's not real, where is technology really on its own maturity curve.
I'm so fascinated to talk to you because you just make me want to ask this question. So someone comes back from the conference, say there's colleague A and colleague B. They come back from the conference. Colleague A is totally buying into shiny object syndrome, but maybe colleague B is bringing something viable and interesting to the table. What's your criterion, your filter for I should listen to this idea or this is potentially snake oil?
Yeah. Well, it's, I guess I would say it's, there's an art and a science to it, right? So the art is the managing the relationship, right? And having the initial conversation and, being willing to listen, right? So, I mean, if you just go into it with an attitude that this is shiny object syndrome and you're not really being respectful to your colleague, that's not a good conversation. So really, listening and trying to understand what it is they're really bringing to the table, trying to dig into it a little bit and understand what is the real underlying need. Is this a solution in search of a problem? That's a problem, right? A solution in search of a problem. So really, but so it can be an opening for a conversation. What is the real problem you're trying to solve? And let's look at what are the right solutions for that problem. It's also, again, an opportunity to educate. There are different models. So, for example, there's a company called Gartner that has this thing called the hype cycle. And so it tracks the maturity of technologies from the time, they first sort of come on the scene all the way to, late stage adoption. And every technology does go through this hype cycle. So it's also an opportunity to educate. And sometimes you might even use a tool like Gartner to say, self-driving vehicles. You want to use self-driving vehicles to transport patients to their appointments. So let's look at analyst reports and see where things like that are on the maturity curve. And then I guess the last thing I would say is using your digital governance. So digital governance is a framework for how decisions get made and funded. And usually there's a set of processes, right? So if you want to put something into the governance framework, there's work that has to be done. You have to kind of like write up almost like a business case on what is the technology, what would you want to do. Again, it's not, the initial submission shouldn't be as onerous as a business case, but you should be able to sort of justify your idea. What kind of impact you think it can have? What is the impact? So digital governance is another way you can sort of manage these new ideas and get them sort of vetted and prioritized accordingly.
So that's one of the steps. You got to get the solution into the door. Implementing the new solution is the next challenge, but getting people to use it is another. You noted adoption isn't always immediate. It takes time for patients and clinicians to buy into, any new concept, much less home hospital concept. How do you approach the cultural side of transformation and manage the slow, steady work of changing behavior?
Yeah, Max, it's a great question, and this is, I think, our life's work in in healthcare technology. So first of all, human behavior is to resist change. The things we're familiar with are things that are safe, right? And we all fundamentally strive to be safe all day, every day. And we become more resistant to change as we age. Hospitals and healthcare systems are also notoriously slow to adapt and change for all the same reasons, right? Because not only are they run by humans and full of humans, but we take care of patients, and safety is paramount. So we don't want to change because we gravitate towards the things that we're familiar with and we know are safe, and we don't want to introduce something that may be less safe. So for our home hospital program in particular, as an example, this was a huge cultural change, both internally. So for our physicians and nurses and other caregivers who ultimately either work on the inpatient units or in the emergency rooms, but ultimately they're the people we're relying on sending patients to home hospital. And they're hardwired to just either admit patients to beds in the hospital. So not only are we introducing change, but we're asking them to change a behavior that they're hardwired to do. But also for patients and families. So patients and families, the idea of going to hospital at home is just completely foreign to them, most of them. And, we're presenting them with something at a time of crisis, right? If they're in the emergency room, it's because they're having a crisis. And so that's probably the worst possible time to introduce a very different idea to them. So in year one of our home hospital program, only 20% of patients who were offered home hospitals, in other words, they had met all the criteria for going home. We vetted them. We agreed, we determined it was safe, and we had all the services and everything to be able to take care of them at home. 20% of them accepted and went home. By year two, that number was 25%. So it took an entire year to move the needle 5 points. And that was, in an environment where, we did a lot of PR work around home hospital. We did, we were in the Wall Street Journal. We were in the Boston Business Journal. We were on local news stations. And so we did a lot of PR work to just even increase awareness of home hospital. We developed solutions that, as soon as we identified patients as even being a potential candidate for home hospital, so early in the screening process, so they're in the emergency room, and we put them through the initial screen that says they may be a candidate. We started engaging the patient them. So again, give them more time so that we're not putting them on the spot and saying, like, I need a decision in the next 5 minutes, right? So again, having people meet with them, provide them information, show them videos of what the home hospital experience is like, all those things. So again, a year of that, and we moved the needle 5 points. So I think it's just evident of how long some of this stuff just takes, right? It'll probably take another decade before patients and consumers even have home hospital as part of their vocabulary of one of the available solutions, within the healthcare system. We have a long way to go. It takes a long time to create this kind of change in healthcare.
Yeah. I tend to agree with you. I was thinking as you're talking about it, because a lot of this work should really be about empathy. And I'm thinking of myself or a loved one who's just had a crisis moment, right? And it's ER or whatever setting that's brought us to this point. And if I'm scared and you're telling me you can heal at home, I may say, no, I want to be here so that if something happens in the middle of the night or XYZ, I'm already where I need to be to be cared for. So there's a certain level of reassurance that needs to take place. I love how you talked about identifying cases using data in your systems to say like, oh, this is a candidate where we might want to start beginning the conversation that you can heal at home. You're not going to need to stay in the hospital. And then I guess you could flip that on its head. There are some people that can't stand the hospital. They find it to be a traumatic, uncomfortable, highly stressful setting. And they would love to hear that they could go home as soon as possible.
Yeah, no, absolutely, Max. And part of the empathy is every person is different, right? And their reasons for wanting or not wanting to do this may be different. I mean, you gave a couple of examples. Hospitals are notoriously noisy and unpleasant places to be and recover. I mean, they're necessary, but anyone that's spent time in a hospital, I think, would agree with that. There's also situations like, what is the situation at home? For some patients, maybe they have a very complex family situation at home that it's not a great healing situation if they're at home. We've also had patients that, they wanted to go home because they're the primary caregiver for somebody else and they don't have an alternative, right? So they want to go home because they're taking care of, a spouse or a child with special needs or some other type of situation. And so they're going home because they don't have an alternative to provide that care to another person. So all kinds of reasons why patients would opt in or out of this beyond just the sort of cultural and educational aspects.
Yeah. But my favorite takeaway from this part of the conversation is use the data to have the conversation and find out. That's so human. What would you like? And uncover what's the right way forward.
Well, especially clinicians and physicians in particular, they believe data more than they believe anyone else telling them something. Right. So it's really the way to get them to fundamentally accept something and believe in it.
Yeah. And what's going to help us unearth and organize said data is AI strategy. So every leader is being AI strategy and implementation, not just thinking about it, but putting the right systems in place. But every leader is being asked about their AI strategy. You've been ahead of the curve here. You're getting AI certification, piloting large scale ambient note taking solutions, and engaging in work like that. From your perspective, what is the most realistic and responsible way to integrate generative AI and automation into home-based care right now?
I mentioned earlier, I've been spending a lot of time talking to founders and startup organizations and people that are really doing astonishing things with AI. So it's been really exciting to do that because to see what's really coming and how it's really going to fundamentally transform healthcare is exciting. So again, no question that AI as a set of technologies has just enormous promise for healthcare. And 10 years from now, healthcare is going to look and operate fundamentally differently because of AI. That said, we're still in early days. And I, again, having spent more time in the past several weeks understanding what's going on in AI more broadly outside of healthcare, healthcare is, no surprise, probably a little behind the curve in terms of AI adoption, but leaning in. So in healthcare, we're in early days, and there's a lot of work that has to be done to train and refine the models to provide a consistently accurate response. I really think about, there's like three legs of the stool, and obviously there's much broader applications, but in terms of the inner workings of a hospital and healthcare system. So the first, there's enormous opportunity in back-end systems. So administrative tasks, claims, et cetera, revenue cycle. there's just tremendous opportunities for AI today, right? So there's low risk there because we're not making clinical decisions, we're not harming patients. So I think there already is activity going on there today, and I think that will be the first wave of AI implementation in healthcare. The second area, I think there's opportunities to use AI as a clinical assistant. And so we're already seeing this done with things like ambient note taking. So having an AI, agent listening to a physician-patient interaction, and when that interaction is done, have the AI agent produce the note, have the clinician review, edit, and sign off on the note. Again, it's acting as an assistant. It is frankly reducing the administrative burden of clinicians. So MGB is about 2 years into a pilot with ambient documentation, 2 years in. And at 2 years in has about 2,500 physicians actively using it. And at 2,500 physicians, it's the largest implementation in the country. So think about that. 2 years to get 2,500 physicians, and that's the largest implementation in the country. So that, again, speaks to the whole, the culture, the adoption, et cetera. I think there is an element of this that not pushing too hard on the pilot, because we want, we want the adoption to happen somewhat organically. We want people who, it's that human change curve. We want the early adopters to gravitate to this, to really embrace it, have success with it, and that will help as we move through the rest of the population to get those sort of, those early adopters and change agents sort of on board. The third area is to use AI to do true decision-making, having it, interpret radiology exams, have it listen to a radiologist dictation and make decisions or draw conclusions. I want to be careful with my language here, even things like make decisions. AI should never, and hopefully will never, replace true clinical decision-making, because there should always be a human element of oversight and ultimately validating that final decision. At the same time, I do think there will be, I will call it routine or mundane aspects, things that are so fundamentally clinically accepted that they could become automated over time. So I hope I'm drawing the right balance there. I mean, as clinicians, I know there's a lot of concern about AI because number one, they don't want their decision-making authority taken away or replaced. They want that final clinical oversight of what's happening. But again, I think over time, there will be things that will become more acceptable to be truly automated, leaving the higher order, higher intelligence, tasks to continue to have, human oversight and sign off. There's already interesting work going on in this space. So for example, stroke detection. So stroke is an example where time is of the essence. The faster that you can detect a stroke, respond to a stroke, administer medications, you will fundamentally change the trajectory and the outcome for that patient. So there are examples where AI is already being used to try to accelerate. So in other words, sometimes it takes longer to get something read and results back from a radiologist than it would for AI to interpret the. And again, it's not an example where AI is making a decision, but they're able to flag much sooner and quicker that AI believes this is a stroke. Here's why. Get a clinician to look at it and hopefully accelerate the diagnosis and detection of that stroke, and again, hopefully fundamentally change the trajectory and outcome for that patient. So anyway, I think those are the three major legs of the stool, and I think largely healthcare will and should adopt sort of in that sequence. Again, start with back-end systems, low risk, high payoff in terms of efficiencies, AI as a clinical assistant or administrative assistant, and then third phase or third wave would be actually supporting clinical decision making. And I want to close this piece, Marks, with one. I heard somebody else say this at a conference. I don't remember the name, or I would attribute it, but I also won't take credit for it. But AI will not replace physicians or clinicians, but physicians or clinicians who use AI will replace physicians and clinicians who don't. So, clinicians shouldn't be threatened by AI. They should be cautious about it. But AI is not coming for any physician's job, right? Like, we don't have enough physicians. Even with the help of AI, we won't have enough physicians or nurses. So I think people should get beyond that concern and embrace it as a tool that will help them over time. I don't think anybody has designs on AI replacing clinicians.
Yeah, I agree with the three legs of your stool and the progression. I think that makes a lot of sense. And I was very frightened when I first saw ChatGPT write up pages of work, and I was like, oh, I'm in big trouble here. And then you step back and you realize human creativity, insight, and intelligence is a long ways from being replaced. And all this technology should work to remove, like you were talking about, routine, mundane, low risk items out of the way so that the doctor can spend more time making eye contact with you. John, how are you feeling? Talk to me about XYZ, connecting and forming that relationship of trust that will lead to better outcomes and deeper understandings of patient issues and what their needs are. So I'm going to touch on some more areas where we've seen some innovation in your work. And, we're looking back at some of your projects and talking about them. For example, the digital hospital of the future at Spalding, and how you were exploring concepts like context-aware spaces years ago. What core principles from that vision still hold true to you, in your opinion? And what does it really mean to build a future-ready healthcare environment?
Yeah, so back in early 2010s, I had the opportunity to design, build, and bring to life a new hospital. And as a CIO, it was just an amazing experience. Lots of CIOs have the opportunity to build additions on a hospital or retrofit space, but when you do that, you always have to try to integrate old technology, new technology, and rarely can you afford to take all the new technology and retrofit it through all the old space. So anyway, being able to create an entire new hospital from the ground up was amazing. It was clear from the start that we wanted technology to be a significant component and to have a significant impact on this new hospital. One of the challenges in the space is that, planning and construction cycles are long. It was something like 6 years from the very early days of designing this hospital till, opening day. And 6 years in technology is a long time, right? So we started by, actually the first thing we did was we hired a consulting firm to come in and do a visioning exercise with our leadership team. So this was a consulting firm who specialized in building hospitals and technology in particular. And so we did a set of visioning sessions with our clinical leadership of, what was their vision for the new hospital and what role does technology play and how did it enable that vision? And then we use that as a foundation to start to catalog the technologies that would support that vision. And then once we had them cataloged, we sort of organized them by must have, nice to have, and a third category that might be sort of innovative future thinking. And we did have sort of fundamental agreement that, we did want to do something, at least one project, if not a couple, that fit into that innovative future thinking sort of space. So again, given that long timeline, 6+ years, the other challenge, once you have those technologies sort of locked in as your must have, nice to have, et cetera, is starting to put stakes in the ground of like, where is that technology going to be? A, on opening day, and B, over the life of the building. Right. So when we started, the planning, Cat5 Ethernet was the standard, like the cable to the plug in the wall. Cat5 was the standard before we broke ground, but halfway through planning, sort of Cat6 emerged, And we went through this whole, financial analysis of what it would cost to do Cat 5 versus Cat 6, et cetera, et cetera. And then what was the life of Cat 5 and what would it cost to retrofit later with Cat 6? So this is the thought process and the kinds of things you have to look at. And ultimately, we did end up going with Cat 6. It cost us another $1 million, but it was going to cost us multiples of that to go back and rewire the hospital later. The context aware that you reference, MGB Digital used to run this innovation program where they brought people from digital together, and they had sort of pet projects. They'd pair them up with someone in the leadership team. So I ran one of these innovation projects, and we picked the new hospital as our project. And the thing that my innovation team came up with was we called it the Smart Hospital. And the idea was that the hospital became smart by using a technology called RTLS, which is basically just sensors that you can track locations of people, patients, equipment, et cetera. And once you have things tagged and you can do that, you can use software to sort of start to make assumptions about, where people are, why they're there. So it's like, the patient's in the bed, the doctor walks in the room, it's 10 o'clock in the morning, it's rounding time, right? So that's the context. That was the idea we came up with, was to create a smart hospital using RTLS technology. So, we put that on our future roadmap as a possibility. RTLS really didn't pan out. And the bottom line is that RTLS as a technology has not converged into a single technology. There are multiple different vendors with different point solutions. And so to accomplish a smart hospital, now we have multiple different sensors and multiple different antenna systems, and it becomes unwieldy to manage. Also, along the way of building this new hospital, digital media started to emerge. So digital signage. I remember that year, the year ultimately that we started to sort of zero in on digital signage. It was one of the presidential elections. And I remember one of the conventions, I don't remember which party, but the entire stage was these huge murals of digital media. And it was just an example that it had really emerged as, you were starting to see it in grocery stores and gas stations and other places. So we put digital media on the map as another potential opportunity. Ultimately, as time progressed, we actually locked in on digital media as a future opportunity. So what that meant is we actually had the architects design in space for the digital media. So basically, we put all the infrastructure in place for digital media as a future. We didn't think it would be there day one, but we also didn't want to have to go back and spend millions of dollars retrofitting the building. And we also didn't want it to look like something that was, pasted on the wall after the fact. So we got to that point in the design that we literally, we locked in on that technology. And then what happened was, again, as time marched on, now we get into, breaking ground and pouring concrete, and, the building starts to go up. And ultimately, the cost of digital media came down. We're seeing it everywhere. And we ultimately found a partner who helped us with our digital media implementation. So we actually ended up doing the project, and it was there day one. And so another first. So Spalding was the first hospital in the world that had digital media built in, designed into the hospital from day one. And from the opening day of the hospital, as anyone that walks through the hospital, they're greeted with, a large mural of videos of, former rehab patients who are, paraplegics and stroke survivors and brain injury survivors with prosthetic limbs who are skiing and rowing and sculling on the Charles and golfing and swimming in the pool. And just, so these are stories of hope and recovery. And as you navigate through the Spalding building, there are these vignettes of digital media that really just bring the building to life as you move through it. It's not a clinical technology. It's not even an administrative technology. But again, it's a story of something that's innovative that really, I think, fundamentally changed the building. But it's also something that we had to track over time, and even had made a financial commitment to before the technology was fully ready. And we sort of got lucky that by opening day, the technology was ready. So, at the end of the day, Max, you want to make investments that as much as possible live for the life of the building. You want to try to anticipate, 20 to 30 years, which is the life of building. That's a long runway. So it's almost impossible to look that far out in terms of technology. But as much as possible, you want to make sure that, the cabling in the walls, the racks in your network closets, the stuff that's baked into the building has the ability to be upgraded and support its function, ideally for the life of the building. The other thing that we identified as a core concept, and this came out of our visualization sessions, was this thing that I called ubiquitous computing. So what our clinical team wanted is anywhere in the building that you needed a computer, you had a computer. Anywhere that you need wired or wireless access, you had access. And again, circa 2025, that just seems like, of course you would have that, but circa 2010, that was not the case. We had some wireless, but it was still a very expensive technology. So we had wireless in some places, but not others. Or you might have it in the hallway on the patient units, but you couldn't go to the far corner of the patient room and still get a signal. So this notion of ubiquitous computing was another sort of core concept that we baked in to the building. And that affected both our wired and wireless strategy, but also where we put devices. So we put devices outside of every patient room, wall mounted. Clinicians didn't want them in the room. That was a decision they made. And then we also had devices on rolling carts that they could bring with them. We had handheld devices. So we did largely achieve that ubiquitous computing concept that the clinicians were looking for.
Incredible. Again, the rapid change over the past, decade and a few years on top of that, maybe, is just very interesting. Like I'm listening to you speak about the media infrastructure and how you positioned yourself to be able to engage in that technology day one, even though you didn't anticipate that. Let's not downplay the intersection of making human experiences better by leveraging technology and being strategic and thinking the way that you have. We have a client that we work with at Venice Health. We specifically have built solutions and pages and environments and spaces for them to tell stories. And I bring this up because I think it underscores something that's so important. There are real people, real families coming into these spaces and having messages of hope, healing. I think some of the more profound things we can learn about ourselves happens when we go through tough times. And unfortunately, that takes place in hospitals and clinical settings, right? But I'm a firm believer that we go through things so that we can help others through things. And you helped put this facility in a position to capture that in a tasteful, artful, and high-tech way that has inspired many hospitals. Because now I go to so many places and there are these really beautiful displays that not only help me navigate physically, but help people navigate emotionally. If I'm allowed to reach that poetically here, and see that I'm in the hospital now, but I won't always be.
Absolutely, Max. This was a little bit of an out of the box idea, right? And it took a lot of convincing to get to yes with my CEO that this was a worthwhile investment. But when we did the unveiling, so in other words, the first time that we lit up these video screens, we had our entire executive team, we had our board of directors, and we lit up the screens and started playing these videos, and there was literally not a dry eye.
Wow.
In the points. It was amazing. The other thing I'll say is, it's now 2025, so it's 12 years later, and you can walk into the lobby of that hospital. It still feels new, and you know what I mean? It does not look dated in any way. 12 years later. So that's also pretty amazing.
So we can plan for the future in some cases.
Absolutely.
And to close, I have one more question. I'd love to bring in a personal philosophy of yours that I've picked up on. You often use cycling as a metaphor to talk about your work. How has your experience as a cyclist shaped your approach to leadership, resilience, and pacing innovation for the long haul.
Yeah, thanks, Max, and thanks for noticing. So yes, I am a cyclist. In fact, next week I will be riding my bike from San Francisco to LA, 7 days, 600 miles. Wow. And what I like to say is that cycling is an analog for life. It requires commitment. It requires resilience. It requires consistency. It requires some amount of fortitude to, stay with it and keep strong and keep going. There's a certain amount of strategy to it, right? So as you're navigating a ride, you've got hills, you've got uphills, you've got downhills, you've got flats. And, so there's a certain amount of strategy to how you're going to pace yourself and manage your body and your ability to get through the whole ride, the whole day, and I think that describes life, right? I mean, whatever you're going through in your life, whether it's your job or school or both or family or like all those things come into play, right? And then, and then there's the inevitable thing that's going to happen that, gets in your way, sets you back, et cetera. But, you just have to keep getting up and getting back on the bike and pushing forward.
Love that. And it's been evidenced in your career and your life, John. I probably have said thank you a million times. I'll probably say it a million more times. Just a really great experience getting to know you and also having you on the podcast. I know you're in the Boston, New England area, so we're definitely going to run into each other after your California your California trip coming up here. So I just want to say thank you for being on the podcast, and this was a ton of great insight for people trying to innovate in this space.
Max, I just want to say thank you again for the opportunity. It's been great getting to know you as well. So and I hope all your listeners enjoy this.
Thank you so much. Thank you for joining us on this episode of the Radian Podcast. If you found this episode insightful, we'd love for you to subscribe on your favorite podcast app or YouTube and follow us on LinkedIn or X for more updates and insights.